Chapter 27, we're going to talk about anger, aggression, and violence. And of course, one of the main things you want to think about is safety. Also, too, sometimes we can help them validate how someone's feeling, but not acting out in that manner, such as aggression, the violence. But they have the right to be angry. We'll also touch on restraints and seclusions, and what are some of the predictors of violence? What can we look out for? What are some of those signs and symptoms that we might see? We're going to go through those as well, and also some of the self-assessment, looking within your nonverbal and besides just your verbal communication with these clients. So we have anger, which is that emotional response, and aggression is actually the action or the behavior. It's okay to be angry. Sometimes we tell people, oh, don't be mad, but it's okay to be angry, because when you hold all that anger in and suppress it, this can lead to hypertension, cardiovascular disease, and any other type of cardiac event. In your professional settings, you may see in a hospital violence, and this is usually more so in your psychiatric units, the emergency departments, and some of you may be surprised, the geriatric units. We also see in the comorbidities PTSD and substance abuse disorders. So please take a moment to look at the two videos that are posted in your PowerPoint. Looking at our patients, their limbic system is what is usually associated with aggression. This kind of sends off those primitive emotions and behaviors. There's also neurotransmitters involved, and of course when we think about serotonin, we think happy thoughts. Well, these individuals have low serotonin. They also have low dopamine, norepinephrine, GABA, your glutamate, and your acetylcholine. Genetics in neurological development occurs during infancy and childhood, so sometimes we may pick up those actions and reactions that others may have, or we may just be predisposed to that genetically. Behaviorally, psychological factors, it is behavioral learned response. And so when they see someone else in the family who reacts in a certain way, they will mimic that and think that's the way you react to something when you're angry. Socially, we may imitate others. We also see children who imitate friends and that group that pulls them in, and they act like everyone else in the group. Patients who are delusional, hyperactive, impulsive, or predisposed to some type of irritability are those patients that are going to be higher risk for violence. And as you can see here, I have another YouTube video for you to watch. When we think about the nursing process and the assessment, there is a review guideline on page 518 in your textbook, looking at your assessment guidelines for anger and aggression. There's usually a history of prior aggression or violence is usually going to be your best predictor of who may become violent when you're taking care of them, when you go back and look at their histories. On your general assessment, you may see increased demands, frowning, clenching of the jaw, reddened-faced, twisting of the hands. Their speech may also increase in volume and rate, or it gets very low, slow, deliberate, and quiet, kind of like your Clint Eastwood. Traumatic history can also impede a self-soothing mode for aggression. So this is also known as your poor coping skills, and they feel like if they don't act out, they're seen as being vulnerable. They also have a self-assessment too on page 518, and it talks about, are you willing to intervene? What are your concerns? What are your vulnerabilities? And then what nursing interventions might have? Are you impulsive, or going to give them an emotion-based response. We have to be very careful with our choice of words and our tone. And again, like I said, nonverbal communication, such as our body posture and facial expressions. We don't want them to know that they are intimidating, and because if they see us being intimidated by them, they're going to act out even more. Also, too, we have to look at the situation. And also, too, do we have enough staff? Are we fatigued? And so we may not have our normal, may not be on our toes as we normally are. And so we might be more, there might be a greater chance for us to become the victim. Again, we need to make sure that we give calm responses, create an environment that encourages us to be able to speak openly and let our clients speak openly about their feelings. Use of humor can be very helpful. Developing a professional support system, and being able to lean on each other, because some of these patients can really try all your patience. Another thing that you want to look out for are those predictors of violence. Hyperactivity, increased anxiety and tension. So they start to become very verbally abusive, very loud voice, maybe a change of pitch, intense eye contact or non-direct eye contact. They may be trying to avoid looking at you. Any recent acts of violence, such as towards property. Stone silence can be a very good predictor that someone is about to become very violent. Drug and alcohol intoxication, isolation, maybe even the environment, the milieu of the area, such as overcrowding, staff inexperience, provocative or controlling staff, poor limit setting, and also we want to make sure that there can be nothing used as a weapon, and which will also create a more violent act. When the nursing process, when we look at nursing diagnosis, this is ineffective coping. We may use stress overload, risk of self or other directed violence. They have a table 27.1 on page 519 that can help you look at some of these nursing diagnoses and also some of the outcomes that go along with them. So I'll let y'all read those, and you can see the signs and symptoms that would go with the nursing diagnosis. As far as intervention and the implementation, the intervention should begin before there are signs of escalation. There is a box 27.2 talking about de-escalation of your clients, and you want to reassure your patient and show that you are willing to help and acknowledge their needs. A primary intervention is actually the de-escalation, especially patients who will escalate very quickly. They talk about how to approach on page 520, so you do want to look over that as well. Always leave yourself an escape route. Don't get yourself boxed into an area. Always use your open-ended questions and never challenge your patient. There's also some interventions, box 27-2 on page 521, so please make sure to look those over. Some other things that you want to think about are the 6 basic considerations for ensuring safety on page 520. And this is, and I'm going to go over these here in just a minute on another slide. And then we also have pharmacological ways to help our patients during aggressive or violent events. So lots of times they may use a second-generation antipsychotic, and they can give that IM where it works much quicker, such as Zyprexa or I can't say this word, Zypresidone, and those are two are widely used. They no longer are using Haldol for that during an aggressive, or violent event. Some of your long-term meds can be your SSRIs, your benzodiazepines, anticonvulsants, beta blockers, lithium, and some of your second generation antipsychotics and the combinations. And these are listed on a table in your textbook, 522 through 523. So in our case study here, it says, what are some ways this new nurse can help themselves remain safe while working? And this is where you want to use those considerations, those 6 basic considerations for ensuring safety, especially safety for staff, such as avoid wearing dangling earrings or necklaces. The patient may become focused on these and grab them and cause injury. You also want to ensure that there's enough staff for backup. Only one person should talk to the patient because they'll feel threatened, but the staff need to maintain a very unobtrusive presence in case this situation does escalate. Always know the layout of the area. Make sure you place furniture in areas where escape is possible. Eliminate any obstacles or hazards that are important to prevent injury if the patient requires some type of physical intervention. You don't want to stand directly in front of the patient or in front of the doorway. This could be interpreting that you're being confrontational, so it's better to stand off to the side and encourage them to have a seat. If a patient's behavior begins to escalate, provide feedback. You seem very upset. This can also help them to explore their feelings and may lead to a de-escalation of the situation. The last one is avoid confrontation with the patient, either through verbal or nonverbal means or through a show of force with security guards. Any type of verbal confrontation and discussion of the incident must occur when the patient is calm. A show of force with the security guards may actually escalate their behavior. So security personnel are usually better kept in the background until they're actually really needed for assistance. Another thing you want to think about is to be a role model. Educate those coping skills, show them appropriate ways to express their anger, and then some self-soothing skills and de-escalation techniques. Help them to identify their triggers. And as a team, you want to be proactive and not reactive. Time out if they have enough control, maybe go into a quiet room, identify stressors, and just to be aware of their environment. Again, seclusion and restraints. Seclusion is involuntary. It's not that they want to go, but it is involuntary. Where restraints, of course, we know about those and their manual method of keeping someone from being able to move around freely. The goal of all this, and as always, is safety for the patient and the others around that patient. They do talk about some guidelines for mechanical restraints, and this is box 27.3, some of those guidelines on page 524. And so those are listed there for you, and they talk about those. So please go through those and look at those. And know your indication of use. It goes over, the legal requirements. And then also, too, on page 524, also they talk about the documentation. There's some bullets at the bottom of the page and on the next paragraph. And it's very important that we make sure that we document very meticulously so nothing comes back to haunt us later on. In this part of a case study, a patient becomes violent and must be placed on restraint. So what questions need to be asked after the incident? And I also would like for you to look at some of the OSHA guidelines for restraints as well. So one of the things you want to think about is, could we do anything better? Could we have done something to prevent the violence? If yes, then what could have been done and why was it not done in this particular situation? Another question to ask is, did the team respond as a team? Were the team members acting according to policy and procedures of the unit? And if not, why not? You also want to think about, how do staff members feel about this patient, about the situation? Feelings of fear and anger are usually discussed and handled. Employee morale, productivity, use of sick leave time, transfer requests, absenteeism are all affected by patient violence, especially if a staff member has been injured. Staff members must feel that they are supported by their peers, as well as the organization's policies and procedures to help keep them safe and keep a safe environment. Another one is there a need for additional staff education regarding on how to respond to violent patients? Then think about, how did the actual restraining process go if you used restraint? What could have been done differently? Do not only focus on whether the staff was acting as a team. You want to know, what could we have done other than a restraint? If there is an injury, has it been reported and has it been taken care of? Sometime in your working career, you may come across lateral violence. So please take a moment to look at the YouTube video on this topic. So intervening in different settings. So I have this listed here for you, and it's talking about, caring for your patients in a general hospital population and in a general setting. Patients with healthy coping skills sometimes become overwhelmed, and they do act out. And then you have those patients who have those very, very few coping skills and have a difficult time. And you may also be caring for these patients in your psychiatric settings, inpatient, and also to patients with cognitive deficits, and also your geriatric population, as I mentioned earlier, are also those who may need some intervention against violence. Looking here, we have a question. A violent patient is restrained. What is the nurse's first priority? And if you know by now, you should know, like the back of your hand, one of the first things we think of is safety. So if you see safety listed there, you know that is going to be it. And sure enough, it is. Ensure the patient's safety. Once they're in a restraint, a patient must be directly observed and formally assessed at frequent, regular intervals for their level of awareness, level of activity, safety within the restraints, hydration. We're going to think about toileting, nutrition, and comfort. So that's the correct answer for this one. And the last one, which patient behavior is a criterion for mechanical restraint? So again, remember, if you're going to use a restraint, you're thinking about the safety of the person and others in the room. So assaulting a staff person is definitely going to be the answer. So indications for the use of any type of mechanical restraint include protecting the patient from harming themselves and preventing the patient from assaulting others. All right, that's all I have, and I will see you in class.